welcome to episode 14 of Future Proof PT. I'm Dana Strauss, and today my co-host, Alex Bendersky, and I are diving into something that could fundamentally change how you think about patient care and even your professional value. It's the therapy value quotient. Here's what you'll walk away with after listening to this episode. First, you'll understand why saying, "I know it works," isn't enough anymore. We're going to break down why subjective clinical reasoning, while important, won't elevate our profession or secure our place in value-based care. Alex is going to explain how the therapy value quotient creates an objective framework that balances cold economic metrics with the warm therapeutic relationships we do value as clinicians. Second, you'll learn a practical algorithm you can actually use. It's not theoretical. Alex is going to share a specific formula that factors in functional improvement, patient complexity, care intensity, and cost. You can plug these into a simple Google Sheet and start measuring your clinical impact in ways that payers and administrators can understand and value. Third, we'll challenge you to think beyond discharge. We're going to push you on something that might be uncomfortable. You have a responsibility to establish a clear therapy prognosis for every patient and think about your value over months, not just visits. That goes beyond the actual episode where you're seeing the patient in the clinic, remotely, or both. So we're going to explore how staying connected with patients post-discharge through follow-up calls, check-ins, and by being their go-to MSK or movement provider creates real value that you can sell to payers and at-risk providers. And finally, we'll give you a reality check about the future. Nothing new. We try to do this a little bit in every episode. We're discussing how AI and improved data connectivity are already being used to identify overutilizers and measure provider quality. The days of endless 3 times a week for infinity treatment plans are numbered, and we'll show you how to get ahead of this shift, even as it's happening. So why should you listen today? Because whether you're working in skilled nursing, an outpatient, or any other setting, you need objective measures to prove your value. If you can't measure it, you can't sell it. And if you can't sell it, your empathy and clinical skills won't matter when budget cuts come or when payers start making decisions about who gets to stay on preferred provider list or gets to join value-based contracts with payers and at-risk providers. So we'd say this episode is for therapists who want to move from hoping they're providing value to knowing they are and being able to prove it. Let's get started. Hi, everybody. Welcome to episode 14 of the Future Proof PT podcast. I'm here with my good friend, Alex Bendersky, my co-host. And today we have an excellent topic to talk to you about. It's about the therapy value quotient. Alex is going to define it and where the therapy value quotient can be both looked at from the therapy-centric perspective and how that may play into the way we as therapists think about value-based care. So take it away, Alex.
Excellent, Dana, and thank you again for allowing me to be a part of this process. It has been a fundamental positive, net positive in my life. So this has been great. Now, right, going on 14, this is a good exploration of all these topics that have been swirling in the head for now a couple of decades. So it's a good way to put conceptual thinking into practical thinking. So yes, value quotient or therapy value quotient. I think the origin of it is identifying an empirical way of assessing value in terms of clinical productivity. And so there are a lot of productivity matrices that are available that are more based on productivity volume or productivity substance or availability of resources, but few look into that global and overarching inclusive productivity matrix that looks into that what traditionally is a dichotomous thinking, either system availability, aka resource availability, or patient resource allocation, patient value, patient alignment, patient-centric values. So this is a way of really defining value in terms of economics, but also in terms of productivity and resources. So this concept and this algorithm comes from acute care process. So the value therapy value quotient (TVQ) is novelty to me because I just stumbled upon a 2018 Journal of Acute Care Physical Therapy, which discussed this as a matrix of identifying resources for an acute care hospital and looking into clinical outcomes, clinical productivity, and having an algorithmic way of assessing and allocating resources towards an inpatient hospital and seeing how these can be operationalized. So first, looking into that ever-present term of value. What is value, right? PTs need to define value, and we've discussed this extensively. Value is really a cost over outcome, right? That's the easiest way of sampling value. How much does it cost, and what is the guarantee that this is going to generate some kind of a net positive or negative clinical outcome? But there really is a mismatch between that very cold, stone cold economic term of value and this therapist driven quote of actually needing to be there for patients. And not everything is reflective in patient reported outcomes. And so there's always an argument of, I know it works, I've seen it work. Or patients need me. And the counter argument is we don't have resources for this. And unless outcomes change in what would be a standardized factor of 4 visits, 6 visits, 20 visits, whatever the predicted factor is, what your threshold for change is, when you are able to show change through that threshold, you can continue care. If there is a absence of change through that threshold of time, you have to discontinue care. So therapy value quotient is in a way of objectifying it and mirroring both of these cold calculating ways of assessing resources and more of warm interpersonal therapeutic alliance driven concepts. So with this, I'll pause and I think we can discuss this a little bit.
So I'm never thinking of it as therapy value quotient. I think I can just bring to this an example of when I was working with transitions of care therapists within and among care settings. A lot of the discussions I would have when I was working on making sure patients were having the right patient journey was talking to therapists about the way that they were justifying their ongoing care and having dialogues, not to question them from a professional standpoint, but to almost encourage them to rethink the habits they had made or that their employers had encouraged over time to come up with justification for keeping patients on therapy. Simple example is in skilled nursing because it's day by day, and skilled nursing facilities are incentivized to keep especially well-paying traditional Medicare patients for long periods of time. And I wish I had this term back then because it's a great one, therapy value quotient. One of the questions I would ask is, what is going to be the difference in this patient? Not just in the week that you think they should stay longer, but what change as you come up with your therapy prognosis? What change do you imagine this is going to have on this person's life? What is going to be the value of this additional week of being essentially held prisoner within a facility versus returning home, where I would argue, and what I'm seeing and reading, that they would benefit greatly from getting this transition, beginning intermittent skilled care and doing some great family training. That's where I see the value that remains in the time that you have with them, which I would argue be in the next couple of days. And a lot of the pushback I would get is, no, they're better off. They're just better off if they're here with me as long as they possibly can. Or they paid into these benefits for years, so they should be able to stay here as long as they want. I mean, we think about how crazy that concept is, that we've taken it upon ourselves to decide that this way that I've imagined I should be using their benefit to interact with my services and not think about the impact on this individual over time, not just day to day you're trying to justify. And we're so, especially in certain settings, we are so habituated to normalize this. And this is one beautiful thing about this equation. It really objectifies that narrative conversation that I used to have into something that's much more tangible. So I'm going to say that I just love it for that. Even for that purpose, it's super valuable.
Love it. Absolutely. And it takes away this more subjective, non-measurable part of clinical care simply due, and this may sound insensitive and it may ruffle some feathers, but I think in order for us to move up in this PT as BCP, PT as a decision maker in a musculoskeletal domain, but also in the healthcare domain, we need to standardize care. We absolutely need to benchmark and standardize at least some parts of care delivery systems in order to have an equal discussion with the stakeholders into what the deliverables are, right? So, in absence of these formulas, in absence of therapy value quotient or anything alike, in absence of these objective measures, we are stuck discussing subjective arbitrary events. I know it works. I think it works. I hope it works. And these are wonderful and great, except they're not measurable. And if you can't measure it, you can't sell it, right? And if you can't sell it, then what is the point? And again, this will ruffle feathers because we are care providers. We're givers. We are sensitive, empathetic type that are selfless. But when the day is done, if you can't assert a specific value to your deliverable, then all your empathy goes to waste because you are going to continue to be discounted. You will continue to be diminished in your role, in your position, and in your importance. And that's like a precipitous slide down. And you and I especially, we spent now a couple of months discussing how do we change the trajectory and create a precipitous glide up. We want to elevate and lift. And so the problem with defining value is we have to take away the subjectivity out of the equation. So the value of the therapy quotient is objective. It takes resource availability, looks into outcome measures, and then allows a fraction of what is it like the change, the delta in a change in personal health values. So I think that's to me is better than just relying on outcome measures alone, which is a formula that a lot of people use. The lack of change in the outcome measure results in change or pathway change from one transition point to another, right? Or a completely profit driven capitalization on patient allocation and patient visits. Like if the patient has a good payer, you are going to maximize on the encounters. And if the patient has a lousy payer, you're going to diminish encounters. This is objective. Like, so I can sell this to a payer or to a risk-based payer saying that we will go completely based on this matrix and potentially add an experience measure into the equation so that we have an algorithm to stand by on, right? And that's like now it's objective. Now we can safely rely on this delta showing us whether somebody's ready to the transition to either a higher price, higher touch event or lower price, lower touch event. So with this, I will pause and I'll let you reflect.
And I guess the perspective that I'd like to bring to this is it's good. Again, requires a different kind of thinking on the part of therapists. But your value is not just the value of the time you're with them. Think of the value as the impact you have presently and the impact your care has and your interaction, not just the billable time, but the way you interact and how you communicate with the patient, the impact that has over the course of the next 6 months or longer, encouraging things like even once discharge, we're not going to use the word discharge, once they transition out of a regular schedule of visits with you, if it's an outpatient as we're talking about, then you're still maybe someone in the practice is making a follow-up call, or you're sending them, once a week emails reminding them some of the things that you had talked about, or, important numbers to call if they need help, because the value of therapy is not just the time you're with them or your billable time in a different healthcare world, in the world where we're a component of a full journey of a patient. Your value is in driving appropriate care and preventing avoidable, unnecessary care down the line. And that having that framework that yes, we have this value of time, and that helps to determine when you should transition a patient off of regular scheduled visits. But think of that as one kind of a Lego piece. That's one component of a longer term episode where that condition is still present in a lot of cases. And it could rear its head again, and it could lead to patients seeking additional unnecessary or avoidable care where you would want them to come back to you rather than going, for example, the pain flared again. I already did PT. I'm going to go, get an MRI, or I'm going to go to the orthopod. When you want them to check back in with you, that's the value that you can sell to payers as your total value. So therapy value quotient, and we're going to share in in what we link for you. But then what does the and maybe this is the next best question for you. How do you envision a value quotient that goes beyond the time at which we transition a patient or helps determine that time?
It's a perfect question, Dana. And I think this, I guess, a more complex way of assessing value of the encounter, right? Like in any complex system, there is a systems dependency on other variables, and it is impossible to account for all the variables that influence and impact clinical journey, clinical recovery, clinical trajectory. So if you start to account for all of the variables, you're going to create a very complex and sophisticated system that is not operational. The alternative to that is to oversimplify things, which I think is what we have been doing now for generations, where this oversimplification leads to diminished value because there's a diminished perception of value. And perception of value, unfortunately, drives value because we just base it on our subjective emotional state. I like it, so I'm going to stick around. Maybe I need this, or maybe that what we previously discussed, the path dependence. The path dependence is the availability of resources feeds the resource utilization. If someone has a neurosurgeon in their medical system, there's a higher probability that that neighborhood, that hospital system is going to have higher proliferation of neurosurgery, spine surgery, right? So the training assets and availability of resources leads to resource utilization, which is not always a value-based position because resource utilization is based on presence. So I know that was redundant and probably lousy English,
No,
but
it's good.
that more objective way, though, it can be accounted for the variables that we deem as important. So you can only select four variables, and I've created a little bit of a hacked therapy value quotient, accounting for lower back pain, right? So just taking and again, we always refer to lower back pain, right? The bread and butter of physical therapy services. But taking someone who presents with lower back pain, you can present that therapy value quotient, and you create a larger level of complexity just with the resources that are available to you. So you look into the functional improvement over time based on a patient-reported outcome measure, like a West Street Disability Index, right? You look into that patient complexity and risk level. You can create a numeric scale for patient complexity that can either be very simple, 1 to 10 numeric scale, and add that into the algorithm, or you can create a complexity scale based on factors that have to do with demographic, prior healthcare utilization. So the sky's the limit, right? Go on the simple side, go on the complex side. You create a care intensity and utilization. So both to this point as well as future care utilization and intensity. Do we have resources to provide to this individual over the next 3 months? Are these resources available to provide at a specific rate, at a specific frequency and volume? And that goes into that formula. And then the final caveat here, the final variable is the cost of care delivery. If the cost of care is high, obviously that has to change that, or it has to change the algorithm into something that will adjust for that. So this is a way, and we'll share this specific formula too, of using a therapy value quotient, which is a little bit more of a simpler algorithm that objectifies the need for clinical care, into a more complex but still available resource where you go on Google Sheets, you plug this formula in, and all you have to do is they just put the numbers in, and out you have numbers. And I will plug again Cody, who has been in this show. But there's so many ways of using these AI tools and language models that are available to you that it takes all of the friction away because you're not even doing that formula. But that is one of the ways of adding these present variables to a higher, more granular predictive viability of patient encounter, patient experience, and the volume of patient care provision. So with that, I will.
That's perfect, and that breakdown is very helpful. There's still some complexity to it, and one of the I guess to bring it back to, like, super simple to make sure we're grasping the simple and we can layer on the formula is, do therapists think about the therapy prognosis and their ability, both their ability as a clinician and the patient's ability, based upon whatever it is? It may be that they have factors that are going to impair their ability to have, quote, a full recovery or pain-free or whatever the metric is you're looking at. That establishing a strong rehab prognosis, both for the long term and the long term means living, right? They're just back to homeostasis, they're living. What is the long term prognosis? The true prognosis, like accurate and really understanding this person, which you should after spending hours with them, right? What is that therapy prognosis? And does the plan of care continue to match that prognosis? And what do you need to do as you move towards transitioning to non-regular or non-in-person or frequent care? What do you need to do to make sure your plan continues to match that prognosis? The prognosis can change. You can predict it wrong. In my experience, ballpark therapists, when they start doing this, get pretty darn good at figuring out what a therapy prognosis is. But encouraging you to think beyond the month or two, whatever it is, or week or two, you're seeing the patient. But what is their prognosis because of these interdependent factors around who they are as an individual in their life? Can you imagine the things that could get in the way of that prognosis over time remaining as good as it is, or for them backsliding? And what should you do, even if you're not directly right now billing for that activity? What is the best thing you or the practice can do to make sure that connection remains intact? Again, even if it's not billable at first, so that that person comes back to you, calls you, and feels that comfort as you're their therapist, right? And you're matching that need, that dynamic that over time changes. If we're going to look at the simplest version and then layer on how can they get more specific and accurate, especially when having to defend this, having a quotient is really nice for that purpose.
Absolutely. So and I love that you mentioned prognosis, that prognostication, right? Like using priors to assess the futures. That level of thinking is an absolute necessity, I think, for any clinician. And most clinicians don't realize that it is omnipresent in a daily encounter. Any clinician that has seen more than one patient in their career is going to start to use Bayesian thinking in prognosis for future encounters of the same condition, both positive and negative. And that fits into the heuristic, again, fortunately or unfortunately, right? Because there is a lot of fallacies and biases, cognitive biases, that play into these prognoses based on priors. So you have to be aware that the prognosis that you're befitting on a patient may or may not be influenced by your experiences and prior exposure, which then impacts your future perception and the future impact. So, but at the same time, any clinician needs to be aware that prognostication and prognoses in both the need for care, the availability of resources, but also that downward trajectory is the only way to think about any clinical encounter. And that's where we go into the deeper level of healthcare allocation, where these are stops on the train. Like you are just one of the stops, and the patient is on a train. They're going to continue to cruise along, whether they choose to board the train or they choose to stop at your stop, whether you're a physical therapist, a neurosurgeon, radiologist, or anyone else. It's based on a lot of factors, economic factors, resource factors, but the patient is still on a journey, and the journey continues for that life. Musculoskeletal problems, for most of their accounts, are chronic persistent problems. And that goes into these bread and butter, your persistent back pain, persistent neck pain, persistent shoulder pain, the 1, 3, and 5 cost to the healthcare consumer in the United States, but also to a lesser extent, someone who receives an acute episode of musculoskeletal care. Your 16-year-old ACL reconstruction patient that engages in physical therapy for 6 months for recovery, like it or not, that patient, that individual will pursue and will need further downstream healthcare for the same extremity. If you look at just the statistics and the distribution, that same ACL recovery is going to result in a faster degradation of the articular cartilage in the same joint. It's going to result in higher level neuromuscular maladaptive and encounters, right? I don't know the proper term for this. And the same individual, once they've created this more of a passive path dependence of consuming physical therapy every time there's a new ache and pain, there's going to be more of a passive consumption of healthcare resources in the future. There was, to segue a little bit into a different empirical clinical work, there was a cool study of pain as a learned behavior, right? And I forgot who published it, but it's something that if you grow up in a household with at least one adult suffering chronic persistent pain, you have an exponentially larger chance and a probability of developing chronic persistent pain, because there is a social emotional aspect to pain processing that has to do with observing someone else who's struggling with something that's painful. So think of that as a factor, right? Can you put that into that therapy value quotient? Do you really need to? But how many therapists ask, do you have anyone else in your family that has dealt with these conditions and these issues, right? But that's just a little bit more of a segue into these higher level complexity, that like the peeling the onion type of stuff, right? But back to the therapy value quotient, I think the reason for this needing to be omnipresent in a clinical networks is because we need objectivity, we need standards, and we need substance. We need something to congeal this fluid state into a little bit more of a solid state, and we need to get there. And if we don't get there, here we are, right? So
And so I'll say something that not everyone's going to like, but therapists as doctoring professionals, I'm speaking to the inclusive you and we have no excuse to not have a therapy prognosis. And I blame other therapists who don't provide therapy prognoses for every individual patient they ever see. I do partially blame you for the way we are perceived. As doctoring professionals, and this is what we have desired as a profession, we should all be holding to that standard of care. Your evaluation should at the very least be able to give you a general idea of that individual's rehab prognosis, and you should be capturing that information. Is it going to be exact on the first visit? No, but it's going to be directionally, if you ask the right questions and it's thorough, it should be directionally pretty darn good. And when we don't do that, we end up with non-ending plans of care that go on as long as we can justify them. And whenever one person has that experience with a therapist and they feel that protracted ache in their stomach when they think about having to go because it's going to go on for a long time, you are at fault for doing that to other therapists who are trying to be more careful and prescriptive about when they see patients, for how long, how they modify and work with them on their prognosis, and how they keep in touch with them so that they remain their provider of choice for MSK care. It is very hard to change the narrative and the belief and the perception of our profession, fee-for-service partially to blame, but we have to own things too. That is negatively impacting those therapists trying to do the right thing. And you could lose that individual patient who's going to have a lifetime of MSK issues. You could lose them to believing in this profession as where to first go to solve their problem. And that has a trickle-down effect on all the people around them who are going to go for therapy and ask their opinion. And it trickles up to their physicians. So with that rant, I'm going to say one other thing. When we think about like the impact of AI, and I know there's a lot of fear around it and there's a whole lot that's going to be figured out, just know that their data is already out there. The connections into those data sources are not perfected. The accurate reporting of claims and encounter data and the speed at which payers can access that is very sporadic right now. But we have folks who are influential in making these decisions who publicly believe strongly that we need to speed up how quickly EMRs are forced to provide their API access to one another and to payers. And by doing that and improving the accuracy of what they can capture right out of EMRs and through claims and encounter data, they can themselves, using AI and excellent data sources, derive what quality and appropriate care is and serve it right up to the beneficiaries. We are not that far away from that. I can't tell you the exact time frame, but we're not far away. And know the data is already out there. And when those API connections are made and we do those extractions, you can map out data and attribute appropriate and quality care to individual providers of all kinds. So it's a good time to take this stuff really seriously and start to prepare for that.
I mean, I think it's right on, Dana. If you don't think that there is a very robust engine that is looking into your productivity matrix on a payer side, there is, and the payers are very much involved in identifying these overutilizers and identifying what causes their overutilization on every account, not just in physical therapy. I think the same goes for surgery. If you look into what happened with arthroscopy, a knee arthroscopy was the most popular surgical procedure for like a decade. And then it was the payers actually that had a positive impact on healthcare consumption, which is great. It was the payers that stopped this redundant, low value surgical procedures that was maiming people and not producing any clinical value. If you have been around long enough, you remember that in the early 2000s and 2010s, knee scope, shoulder scope was almost as frequently performed as an antibiotic prescription for an ear infection, right? Anytime you had an ache, and if you wound up in an orthopedic office, you would get a scope. It was just like, let's go and see what's going on in there. And unfortunately, what would happen is that creates now a very different and quick path to a disability and a very quick path to a downstream negative health effect or an iatrogenic effect. So this iatrogenesis was caused by low value care. It was the payers that looked into it, looked into the outcomes and said, no, 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 we're not going to pay for arthroscopy anymore. We need you to stop. And when the orthopedic surgeons stopped getting reimbursed for arthroscopy disappeared. Now, if it was a valuable clinical intervention, then even if the payers weren't paying for it, you would still expect orthopedic surgeons to perform it. And all of a sudden, you see something that in the factor of like 70% decline in arthroscopy. Does it mean there's better procedures out there? No, I haven't seen any. It just means that it was a simple procedure to do. It paid well, and it was associated with higher level clinical utilization, and it stopped. So, right on with that. I think another point to discuss quickly is what is the likelihood if you, as a clinician, once you have an end in sight, so for these capitated or risk-based visit products. If you know you only have 10 visits to take care of this individual, and your conversation from the beginning starts with, we have 10 visits to take care of you, to do what we can to help you overcome this barrier, but we only have 10 visits. Let's make the best of it. What do you think is the likelihood and probability that that consumer is going to be much more compliant with their exercise program? Is going to be much more compliant with your lifestyle modification choices? It's going to be much more compliant with ancillary or second order effects like improving their sleep hygiene, improving their diet, right?
Or don't lose your thought, but spreading the visits out more. Maybe
Sure,
twice
sure.
a week is just fine for 5 weeks
Yeah.
versus 3 times a week and keeping up that pattern.
Oh, yeah,
Keep
like the
going.
3 times a week for infinity. 3 times a week times infinity, right? That was like in a web PT, like a progress report, always like 3 times a week for forever. But like, and please authorize. But so that I think it's important that like having this quotient, having this ability to capitate what you need. And again, I know it's gonna have some potentially negative effect for like that people that are listening, but capitation can have a positive effect too because it gives you an end in sight. You know what you're working towards, right? When you are running a race, your economy, how hard you push is very different when you're on mile 1 versus mile 25, right? You hold yourself back in the first 13 miles, you push moderately in the next 7 miles, and then you go all out in the last 6 miles because your economy has to reflect to how close you are to the finish line. When you are a patient consuming care, if you only have X amount of visits and you spread them out, as you were saying, Dana, over a period of time that is allocated to this individual, that individual is a lot more likely to have agency and autonomy in their self-care. They're a lot more likely to have choices that are positive towards the better clinical outcome. So that's my spiel. I think that's definitely a something to discuss, right?
And I love that you just brought up capitation because I'm gonna throw this additional angle at capitation. Yes, there's folks who have positive and negative things to say about capitation. If you're thinking about working towards some capitated agreements, don't just settle on straight capitation. You want because especially if you do a great job at establishing a good prognosis and in thinking about how you're going to connect with that person, even when they're discharged, just a little, stay connected, engaged. You want to have the potential to earn additional dollars, right? You want X dollars. And then at the 6-month mark, I want you to look back as a payer and determine whether or not their longer term outcome and their ability to avoid other care was better than what you would expect it to be and actuaries can figure all this stuff out. Was that risk adjusted experience plus time after better than expected? And if it was, and I provided more value to you because I had them avoid $1,000 surgery and a couple $1,000 MRI and blah, 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 and an inpatient stay, then I want a fraction of what I saved as a reward. And what that then creates is a feedback loop. They're thinking about that person's journey and a look back period of something like 6 months where you compare that episode to other similar episodes. You want a reward for the value that you helped the patient get, the system get, the payer get, all of these things. We have to learn to ask for what you want. We have to start getting comfortable with, first of all, knowing that this is possible, that actuaries can look and compare one episode to another and reward providers. There's a look back period, and they look to see whether or not just did they spend less, how are those outcomes? And then we're going to give you a financial reward for doing better to care for patients and keeping them well. I mean, all this is really well aligned, I think, with the way therapists want to practice. You just have to know that it's something that's happening and that you can tap into initiating that conversation.
100%. I think 100%. So I will probably share a little caveat of a poorly quoted historic reading, and I don't remember the book I read, and I don't remember the period when I read it, but it was a healthcare model that looked into allocating specific resources, specific funds for any individual at the time of birth. So when you were born, you would have X amount of capital allocated for your lifetime of spending in healthcare. And it was allocated in a fund. The fund would grow as you would grow too. So your positive health choices get rewarded, your negative health choices get punished. And when you run out of capital and you're 60 years old, the rest of it has to be out of pocket. And if you make positive choices, then at a certain threshold, you get to keep that money. That's your retirement fund, right? So that was one of the healthcare models that made perfect sense in a responsible society. That if you are responsible about your healthcare choices, about your lifestyle choices, then that model will work. We are not a responsible society,
I love that, though. That is genius.
right? Right? Yeah. So that was like, and again, I would wish I could quote where, but yeah, but it's yeah, in a responsible society, I think this is a way for you to actually think of your health as an investment. And so any positive choice you make, that these are going to be your funds at the time of retirement. Maybe you can retire earlier because you were able to collect such a large funds. To wrap things up, right, and to make the full roundabout, that risk adjustment, right, and the value quotient in healthcare. The importance of value quotient is not about the label of what therapy value quotient is. It's about the need for objectivity in prediction and predictive processes, and in how we operate clinical care in a musculoskeletal world or beyond, right? But that's subject matter. That ability to create some kind of an algorithm that helps you prognosticate the total need of resources and total need of care based on the availability of resources, and the resources should be subjectively kept so that you don't run into the incentive of overutilization.
I love that. Yeah, that wraps up, I think, what we are going to talk about for the day. Part of, I believe, our responsibility is to identify what things could go wrong. And you don't have to be exact about it. You know, someone hasn't been that compliant, or there's certain things that they're dealing with where you think, they mentioned going on this, as simple as mentioned going on this trip, and it's going to be a long flight. And maybe I check in with them when they get back to see how they did. And if they fell off, maybe we should have a conversation and have them come back even for a visit or two to check back in. If not, but this person is still your patient, just like a primary care physician thinks, this is my patient. They come to me. Imagine all of your patients. You're always their therapist. That's the impression you want to give. Their episodes are ongoing, and we owe it, I believe, to the patients that put their trust in our care to be thinking about them as whole people beyond the time when they're on a schedule with us. And that we are part of the care team. We build that trust. And as you build the years of little interactions here and there, you get even better at knowing exactly what they need and how they might need it. And as data, again, gets better and better, we are going to get more exact, whether we like it or not, about what patients need, who delivers the best quality and value. so that they're ready for that. That's what we hope for all of you listeners.
Oh, absolutely. You become the stakeholder in somebody else's life, right? Like you are a gatekeeper and a stakeholder in a wellness and well-being, and so you have the expertise and experience to be that resource. And so being a resource is like that's the key. So that is awesome. Absolutely, and 100% right on.
All right, thank you, and Alex, you're the best co-host. It's so much fun every time. And thank you all for making it to the end, and we will see you for episode 15 in the not too distant future. Thanks again. That's a wrap on episode 14. Alex and I covered a lot of ground today, from the practical mechanics of the therapy value quotient and the concept to some hard truths about where our profession is heading and what we need to do. Here's what we want you to remember. The days of defending your treatment decisions with "I know it works" or "the patient needs me" are ending. The healthcare system is moving toward objective measures, whether we're ready or not. But here's the opportunity. You can get ahead of this shift. Some ideas for homework after the episode. Start with one thing. Establish a clear therapy prognosis for every patient you evaluate. We want to veer away from "they'll get better," but towards a specific time-bound prediction about their functional trajectory, as well as a long-term prognostication of their functional status over the course of the next even 6 to 12 months or longer. Practice this until it becomes second nature, because it will. Then think about one patient you're currently seeing. Try to apply Alex's framework. What's their functional improvement trajectory? What's their complexity level? What resources will they need beyond your billable time? Think truly, what do they need? How can you stay connected to them after they transition off regular visits? What might they need from you in the future? Remember what Alex said here. You become a stakeholder in somebody else's life. You're not just treating their current episode. You are really positioning yourself as their go-to MSK provider for life. That's where the real value lies, and that's what you can sell to payers in a value-based world. Here's one final thought. If my rant about therapy prognosis made you uncomfortable, well, good. We need to hold ourselves to the standard we've asked for as a profession. Every time a therapist provides non-specific care or care that's seemingly endless, it hurts all of us. But every time you establish clear prognoses, you measure your impact, and you think strategically about long-term patient relationships, you're elevating our entire profession, and we need to hold you to that. The future of physical therapy isn't about doing more of what we've always done. It's really about proving our value in measurable ways while maintaining the human connection that makes us essential. Thanks for listening to episode 14, and if it resonated with you, share it with a colleague who needs to hear it too. If you're ready to start implementing these concepts, we'll be back soon with episode 15, and we'll be diving deeper into building your value-based practice. Keep future-proofing your PT career, and we'll talk to you next time. Thanks.